My name is Kenny McKinnon, and the title of this presentation is Understanding Detransition in the Context of Mental Health. I'll be presenting results of the DeTrans Canada study. So I've been involved in transgender care and research for about a decade, and I myself transitioned about 12 years ago. And over the years, I've had a couple friends detransition. And within our current cultural milieu, we have very big transgender narratives that we're all just trapped in the wrong body, that our gender identities are always innate and immutable, and that gender-affirming care is always life-saving. And for many, these narratives hold true. But my latest research examines a subset of the trans population whose experiences give us a different point of view. So my entry point into research on detransition emerged from my doctoral work, which examined the delivery of gender-affirming care in Canada and a desire to improve access and care practices. And this work is personally challenging for me. So what is detransition? Detransition refers to stopping or reversing a gender transition. So that may involve discontinuing or switching gender-affirming hormones. It may involve surgical reconstructions or surgical reversals, or electing against interventions that were once expressly desired. Some authors, including myself, are starting to reserve the term detransition to also correspond to a change in an individual's self-conceptualized identity following initiating a gender transition. And some are a bit apprehensive about the word detransition. And the reason that I do use detransition in my research is because I'm a community-based researcher. And so I do really value preferred language and terminology of the study population of interest. And so that means recognizing that a lot of individuals with lived experience do use the term detransition as well as detrans to describe their experiences. So what's detrans? Detrans is not a new gender identity, but it is a term that describes a process or an experience. And so some individuals may label themselves as detrans, and they may use that in association with their sex, their gender, or their sexuality. So someone may describe themselves as a detrans male after having lived as a trans woman, detrans lesbian after having lived as a trans man, or detrans non-binary refers to someone who previously affirmed a binary trans identity like trans man or trans woman. Importantly, detransition is not the same as regret. So these are two discrete concepts, though there is some overlap because a lot of detransitioners do have regret about their past gender transition, but not everyone does. And some actually fuss and do not feel regret about their past medical decisions. So how often does detransition occur after gender transition? So I will just point out that our current data is very limited because of different concepts used in research, as well as relatively short follow-up times. But a few studies have come out in the last few years, in England in particular. So there's been 3 studies that give us some indication that detransition in association with a change in gender identity occurs in roughly 7 to 10% of people who initiate a gender transition. And so these studies do favor younger folks as well as AFAB. In the US context, there was a study that came out by Roberts et al. In 2022 that looked at healthcare administrative data in a sample of 952 young trans people that found roughly 30% discontinued gender-affirming hormones after 4 years. Now, I want to point out, though, that this is not a study on detransition. And so because of the data source, there is no indication of a change in gender identity or the reasons for discontinuation. So that's a real limitation of that study. And there are lots of limitations of all of these studies that I just unfortunately don't have time to get into. But what I wanted to say is that there are very few qualitative inquiries into the experiences and care needs of people who are detransitioning. And so that is where our study comes in, the DeTrans Canada study. So we examined what are the experiences and care needs of people who are detransitioning. And we also looked at people's gender identity, shifts in gender identity as well. We conducted a constructivist grounded theory, which is an iterative, inductive approach to interview-based research. And in constructivist grounded theory, reflexivity or positionality is also very important. So what is the researcher's position relative to the study population? So this is really important, and I want to take a minute to talk about my positionality as a trans person. So I don't identify as detrans or detransitioned. And so I do consider myself to be an outsider to the detrans population. And so in conducting this research, I really had to bracket a lot of my prior assumptions about detransitioning that I had learned through my years in trans community. And that, that has really shaped my process through this research. The rest of the research team is also composed of other trans and non-binary and cis researchers. We're all LGBTQ+, and some of us have actually detransitioned. And we did consult with a number of detransitioners through the whole study process. To recruit study participants, this is the flyer that we circulated. We circulated this flyer over social media, including DeTrans support groups, and to 6 clinicians in urban centers across Canada and through a participants network. So we also used some snowball sampling. During the recruitment period, we were contacted by about 45 individuals, and we ended up consenting 28 individuals who completed the full interview and demographics question and who met our eligibility criteria. Eligible participants were aged 18 and older, living in Canada, and participated in either English or French interviews. And they also met some other eligibility criteria around self-identity. In interviews, we asked people a range of questions about their transition and detransition experiences, their gender identities, their recommendations for care providers around transition and detransition. And we applied the constant comparative method of analysis, which is important in constructivist grounded theory. And we also did inductive coding and thematic analysis in order to interpret participants' experiences of transition and detransition. Among the 28 participants, there was a wide age range between 20 and 53. The majority of the sample were between 20 and 29. 64% were assigned female at birth. 57% indicated more than 3 past gender identities, so there was quite a bit of gender fluidity in the sample. And 57% self-labeled with a mental health-related disability. And these included bipolar disorder, borderline personality disorder, autism, schizophrenia, PTSD, ADHD, and depression or anxiety. In terms of race and ethnicity, the majority were white and 18% were multiracial. 27 out of the 28 initiated a medical transition, and of those, the majority were ages 24 and under. The duration of the transition to detransition timeline was a mean of 3.68 years, and there was again a wide age range, or a wide range from months to 12 years. We also asked participants about their current identity, and the majority identified as non-binary after having affirmed binary trans identity. But you can see there was a lot of complicated overlap in their identities. So some identified as non-binary and trans, some as non-binary male and gender fluid, some as exclusively female, some identified exclusively with their sex, and 3 participants were currently undecided on their gender identity at the time of interview. So all the participants started out their transition identifying as binary trans people, like trans men or trans women, and they experienced their gender dysphoria as very real, and they sought medical interventions to affirm their trans identity. But many also felt that through the process of transitioning, their mental health declined, or some received new diagnoses after initiating their medical transitions. The one participant shared, after a suicide attempt, I ended up in the ICU. I was in the unit, I think, for 14 days, and then they transferred me to psych. At no point, nobody's questioning if transitioning is benefiting my mental health, because it clearly wasn't. But it was considered this separate, untouchable thing that's innate, that couldn't be playing a role and factor into my mental health. I started DBT, which is for one of my diagnoses, borderline personality disorder. So I was diagnosed in the first hospitalization in 2017. And one of the symptoms is an unstable sense of self. And no one saw that as like, maybe something else is going on. I ended up detransitioning 2 months after I finished DBT. Another participant who also detransitioned following DBT and a diagnosis of BPD shared, I just wish someone would have gone into the trauma first to really figure out what was going on, why I was feeling the way I was feeling. Because the feelings of gender dysphoria were real. I hated my breasts, I hated my genitals, I hated my body. What made me feel frustrated was after I had my double mastectomy, my mental health started spiraling pretty quick. I had this expectation that transition was just, everything was going to be better. Like I was going to be this new person and everything was going to be fine. And it just wasn't. So many participants shared that they needed more mental health support throughout the gender transition process and that they would have benefited from a more comprehensive assessment when they were making treatment decisions. For some, the process of detransition brought up really divergent feelings and care needs. Some detransitioned because they felt that it would improve their mental health. Some had felt very dissatisfied in their new gender role. Some felt that they transitioned to the wrong gender and that they actually were more non-binary. So this individual who shifted from binary to non-binary shared that detransition started when I was in a really low mental place. I felt better when I was off testosterone. I was thinking about it and being like, is this something I'm doing to be harmful to myself, beating myself up because transition's not going the way that I anticipated? But it wasn't, because my memory improved, my brain fog lifted, and I felt more me than I had in a number of years. So then I made the mindful, conscious decision to just stop tea completely. Another participant shared, I feel like I deserve better care in a sense, that they actually took the time to figure out where those thoughts with wanting to be a boy were, why I wanted to go on testosterone. I was so young at the time. Like I wasn't even really thinking about these things. I was just thinking, I want to get away from being a girl. Today, my gender expression is not where I'd like it to be, but that's for a future thing. I've been trying to come to a place of peace where I don't put blame on other people, but definitely not my mother. I mean, she was just doing what she thought was best, what she felt informed to do. Another participant who also transitioned at 15 said, I started testosterone at age 15. At 14, I was presenting as very masculine and I was in the system. The group home staff had brought in a gender identity specialist and they asked me, this is transgender, are you this? I interpret it as a solution to a lot of the things I was struggling with. This is going to fix why I'm always sad. I also saw it as a portal to escape my girlhood, AFAB childhood. I wasn't viewing it as this is something I'm doing for the rest of my life. This is something that's going to impact my social life, my romantic life, the way I see myself, the way I like myself, my body. I don't know if I would be this masculine if I didn't alter my body in a way where I can only exist. I had a pretty male socialization for a long time. I don't think I can undo all of that. So many participants in the sample detransition due to a confluence of many different factors, such as mental health challenges, because their own personal definition of their gender changed or their gender identity changed, and because some were unhappy in their new gender role. Some also experienced trans-related discrimination in the workplace. And it was a challenging process involving a lot of self-reflection, including factors that led them to transition in the first place, and working through really complex feelings such as regret, and a feeling that these gender affirming interventions really didn't meet their needs in the long term. And many also challenge this idea of the cisgender, transgender binary. Their experiences existed in a more liminal space. So a few discussion points. It's very difficult to predict how gender-affirming medical or surgical interventions will be tolerated by individuals over the life course. And that's because these interventions and our bodies interact with the social environment. They're very transformative. And so changes in self-conceptualized gender identity after initiating a transition can occur for some people. And when it does, detransition and or regret seems to happen between a range of months to over 10 years. But currently, little is known about causal factors or pathways, but we cannot ignore the socio-political context or gender minority stressors of being transgender, because transgender lives are challenging. So the WPATH standards, most recent version, the SOC 8, recommends an assessment for adolescents and adults who are considering medical interventions, and that assessors should be able to identify between gender dysphoria and co-occurring mental illnesses. But this is very difficult and requires a lot of clinical trust between trans people and their providers. When detransition occurs, it's very socially, medically, and psychologically challenging. And healthcare avoidance is quite common amongst this population due to shame and fear of provider judgment. So what can providers do to ensure that people feel more comfortable seeking detransition-related care? First, I think we need to normalize gender questioning and gender fluidity throughout gender transitions, because this does happen. And when it does, it can be very destabilizing and isolating for people. Also, like in other domains, just avoiding making assumptions. So avoid assuming that patients feel that their transition was a mistake, or that they feel ruined after detransition. At the same time, avoid assuming that detransition is just another transition or a gender journey. Some people may resent this positive kind of reframing. Detransition often involves complex emotions such as isolation due to social rejection, often from trans communities, mistrust toward past care providers in the medical system, and grief or mourning about changes that have been made to their body. For some people, these feelings might be temporary, but they also need to be acknowledged and processed. So finally, a few limitations. This is an exploratory qualitative study. We do need more longitudinal prospective studies into detransition. It's a cross-sectional design. And these results are not generalizable to all detrans or detransitioned people, and certainly not to the broader trans population. And experiences of transition and detransition are very heterogeneous, and no one's story is the same. Thank you to all the participants who trusted us with their stories. Some references, and feel free to stay in touch. Thank you very much.